Dear all, dear uh, Ingrid, I would like to thank for the kind invitation. Uh, I'm today replacing actually Burak Turna, one of my colleagues, that he was not able to attend the meeting due to family issues and professional obligations. Uh, he is irreplaceable, but I'll just try to give you some information about the topic that I'm dealing with nowadays. I'm coming from Istambul University. It's one of the first universities in Turkey, and it was established in 1453. And some scholars will say that it was established before Oxford University in the Byzantine Empire, about 800 AD. Today, my talk is going to be about the robotically assisted endourology on the upper urinary tract. Uh, Unfortunately, Burak is not going to be with us today, and I will try to cover also his talk, which is also robotically assisted endourology in the kidney stones. Um, my conflict of interest is EndoRobotics and AI, a startup company that we have recently started a month ago, but has nothing to do with this presentation. I would like to mention about the robotic endourology cases in the upper tract. They first started in 2011 with Desai and Indeber Jill when they tried to figure out and locate the stone with an 14 French outer sheet of ureteral access sheet. And their test was encouraging to access the calculi in the kidney, but the test after the test has finished, they couldn't go on with the passive flexion and deflections of the system they have created at that time. 3 years later, a new platform arrived from Turkey. It was Remzi Salam, who was doing a flexible ureteroscopy and who was getting really tired about doing flexible ureteroscopy with the lead gowns and tried to have an ergonomic manipulator at that time. And then the academicians who were on the top of the field, Glenn Preminger, Olivier Traxler, Russ Feiler, and Kemal Sarıca was on the team, where Kadedu said that it was another industry-driven, unsupported marketing campaign for robotic endourology surgery. Following that, Klein reported about 400 patients with a robotic system for endourology for the upper tract, and the results were a compelling rationale for changing paradise patterns with additional cost. Proietti Silvia said that the spatial orientation of the scope was quite in a good stability manner, and Kemal Sarıca said that it saves time and protects the laser fiber. While during the era of pandemic, it had the opportunity for the surgeons to be away from the patients and protect the patients. The platform is a manipulator actually that you have more ergonomy, as you can see, or you can have some precision movements with three movements that the flexible ureteroscopy obtains. It's rotational movements. There is also insertion movement, flexion and deflection movement, as you can see on the screen. This is actually a kind of a manipulator that you can do with your hands, and if you connect the ureteroscope to the robotic arm, then you can do it from far away. You can press a laser pedal, also you can insert the laser fiber from the screen, and you can control the respiration with either integrated respirator support or with special kind of belt, and you can use them with any kind of ureteroscope. It was a Avicenna Roboflex that you have seen before, and this is another robotic platform that uses a console, and it's available for every ureteroscope in the market. And the manipulation of the robotic arm is happening with a Nintendo console. It's like playing video games. This is a wireless controller and the surgeon could be close or far away from the patient. And the movements are again the same rotational movements: insertion, flexion, and deflection. And for the support, there's an accordion system. And this is the robotic arm of the ILI platform that is from France. And this is the laser fiber insertion and the rotational movements of the arm. Following that, the Korean colleagues started to do a porcine model. The investigator was Sung-Young Cho, and did in 4 weeks and 47 patients, and they called the platform Easy Uretero. And following the first initial trials, they upgraded the system to the Zamenix platform. So here you can see the movements of the robotic console plus the movements of the ureteroscope that is controlling with the robotic arm. Also the laser fiber on the right screen and hitting the stone, with additional features of stone guidance during stone retrieval, path memory, and auto driving. Also, the Chinese colleagues had done another robotic platform which is not commercialized yet, but there is on the papers that we see. They also use the same system, the same concept, with a robotic console and robotic arm, while they would do haptic feedback. We know that the Monarch platform from Johnson & Johnson was created initially for bronchoscopy, for biopsies, and but nowadays it's used for mini percutaneous combined surgery. And all of the platforms have different kind of features, but all of them are ergonomic. They protect from the radiation. Some of them have X-ray pedal, some of them have the lasering pedal. Some control the irrigation, and none of them has the haptic feedback yet, but soon they will. We have the intrarenal pressure control, mostly from the ureteroscopes nowadays, or the access sheets. Some have the basketing features, and some are going to support 5G, and some support the PCNL cases. And this was the dilemma of endourologists, actually, whether we should use them or not at the moment. We know that they are not hype at the moment, and they are not prototypes, as they started in early 2000, and 25 years later there are multi-platform devices. On the left side of the screen you can see the initial ergonomic devices with the idea of ergonomy that was created, and nowadays they are in a multi-platform basis. These are clinically validated robotic platforms with meta-analysis of 700 patients. They have similar stone-free rate and similar complications. They do enhance the precision and reduce the operational fatigue. The stone-free rate are similar, just need to be standardized in reporting and the cost-benefit analysis. So as I say, the similar operation time and the complications are the same. Nowadays they are in a multi-platform availability. This means that you can control in a multi-platform. On the left screen you can see the Roboflex Avicenna from Turkey. On the right side you see the South Korean robot Zamenix. On the left bottom you see the ILI robot from France. In the middle you see the Monarch platform, which you can do also the mini percutaneous surgery. And on the right, probably a futuristic option that will come in a couple of years with augmented reality, that you can operate in different rooms, which could also be done for the telesurgery. They are clearly ergonomic. As we see, the ideal posture for any kind of surgery would be a straight position that we see as in the figure, but this is impossible when you are doing the surgery. You have to rotate your arm, you have to be straight, you have to press the laser pedal or the X-ray, your hip joints, your wrists, are also moving, and you have a clear non-ergonomic position during the surgery. So the percentage of the operative time surgeons spend in various high-risk positions, you can see with the red areas of the figures. And also, the most surgeons spend much time on non-operative work days at a poorly configured workstations, and the stress is the same on the muscles and joints affected by performing surgery, especially the cervical neck. 90% of the practicing urologists say that they experience work-related pain, and most of them have difficulties doing the surgery. Especially the surgeons hyperflex their wrists, and this is a major injury in a long standing operative hours. And on the left side you can see another prototype, a hyperflex designed from one of the urologists, Sardar, who is having an ergonomic platform, not a robotic one, and he may in the future go for robotic multi-platform cases. So they have clear ergonomic value, and also they have radiation advantages. When you operate it far from the patient, in case you have the first scenario as you see on the left screen with the A, you have the highest radiation exposure. It's 160,000 millisieverts. And in case you are far away and protected with a wall, then you have about 7 millisievert. It's a huge difference, 160,000 and 7 millisievert radiation dose. So it's a practical adoption for a couple of centers. These are the early adapters in Germany, in UK, and in Poland. And nowadays, there are in different kind of universities, these kind of platforms in Cambridge, in California, Irvine, King's College, in Qatar, in Izmir, and also in our institution, Istambul University. Also, the Korean robot is in 11 centers in Korea and in Indonesia. They are awaiting the FDA for US market entry, and the Monarch is awaiting again the FDA for the US market entry, and is being utilized in one center in US, whereas the Illy robot is circulating at the moment. So when we consider for the cost-benefit analysis, there was a study from Lurango and his friends. They considered 211 residents from 21 European countries with median age of 30. A total 5-year residency cost would be about 90,000 euros. So you would invest in a 90,000 euros and you would have an ergonomic disadvantage for the longevity of these surgeons. The cost effectiveness data remain limited for this kind of robotic platforms, but the upfront cost seems to increase, creating adoption barriers. The long-term investment actually would be for the cost-benefit analysis. They protect the surgeon longevity and decrease the musculoskeletal strain. So this is decreasing the hidden cost of injury and the lost productivity. Nowadays, they are more stable and they provide superior stability for crucial cases and complex cases and allow the elimination of human tremor. Here on the left side, you can see the precision of the robotic platform. It's lesser than 1 millimeter, the fiber that you see on the left screen, while the tumor, the upper tract tumor of the patient is about 2 millimeters, which you can precisely do a lasering procedure where that would be much more difficult with your own hands. So they maintain the surgical performance, and also they work well in difficulty anatomy cases with high complex stones, and they are effective for larger stones. Especially the Monarch, the RoboFlex platforms enable the combined mini PCNL and flexible ureteroscopy cases. These days, these are the experimental cases from our department that you can see the robotics provides stable platform for AI with respiratory compensation. There's path regeneration and stone size guidance. and intraoperative navigation and differentiation of tissue and stone. They also have compatibility with accessory devices like ureteral access sheaths, flexible and navigable ureteral access sheaths. Monarch has a steerable suction catheter, whereas the RoboFlex having laser control and Zamanix having laser control and basket control. On a closing thoughts, I will say that robotic flexible ureteroscopy has reached a level of indispensable capability in endourology. And regarding ergonomics, they are highly ergonomic, they decrease their radiation, and they increase the case volume. So conventional flexible ureteroscopy remains effective, but robotics are safe, they are validated, technologically advanced, supports longevity of surgeon, and enables next era of integrated AI and automated stone management. I would like to thank you for your patience and listening to me, and I would also like to invite you to join after Buenos Aires in this year, after Australia next year, and after Glasgow in 2028, in 2029, I would like to welcome you in Istanbul, and I will be glad, and it will be an honor for me to have you in Istanbul in 2029. Thank you for your attendance.
Thank you so much. We have a special guest online, Burak. He would like to say hello. He would like to participate also in any questions and to be answered because he was doing almost the same conference, so they decided that he will do both, but he's there. Burak, where are you? Hey,
Hello. Hi.
se oye. No sound, Burak.
Well, I can hear you.
Okay, now we can hear you. Hello there.
Hello to all from Turkey. I am terribly sorry I couldn't make the meeting this year. However, I really enjoyed my time in Panama, and I would like to thank Ingrid for organizing such an event. And I also would like to thank Cevat from Istambul. He is one of the rising stars of Turkish endourology, and I thank him very much for representing our country. And you know, as you may already know, this robot is specially designed for flexible ureteroscopic use, and the company is a Turkish company, and we are our thoughts are this robot specially designed for urinary stone disease will be an valuable tool to centers with high volume stone disease.
Any answer from the audience?
What are the main benefits for the patients?
Micrófono. Benefits, Burak. Hold on.
Well,
Can we have, hold on, un micrófono? So why would you say are the benefits from using these robots
For patients.
for patients, says Pablo Contreras. He's asking.
yeah, thank you. Hello, Pablo. So, as you already know, we are dealing with more and more complex stone disease ureteroscopically these days. And then, you know, sometimes we deal with large stone burdens, complex stones. And in these kind of scenarios, you know, there is a concern for surgeons' fatigue in this long operating hours. You know, you have to really work hard to clear complex stones in kidneys ureteroscopically. And use of this robot helps you sit in a comfortable position, and then also, as Javad has shown in his during his presentation, it maps out the stone, and then you can really kind of use the robot in the surgeon's favor to tackle with complex stone disease with less radiation exposure, with increased ergonomics, and then with this demanding complex stone management. But when you have a simple stone, let's say a renal pelvic stone less than a centimeter, you do not need to use this robot. However, in Turkey, in centers with high volume stone disease, such as Istambul University, where Cevat is the lead endourologist there, they are really benefiting and standardizing the procedure in these patients. That's my initial thoughts.
I'm sorry.
And also, I would like to thank Pablos for this. There's a great debate that the outcomes are not for the patients, but are for the surgeons. Therefore, all the institutions, including the governmental or private practice, they wouldn't care about surgeons' ergonomy or longevity so that they could replace any kind of human being with another human being at the moment. But I will say that in case nowadays that we have accessory devices like fans, the aspiration sheets, we all in all extending the procedure time, the intrarenal procedure time, and we are not mostly doing percutaneous surgery, but doing flexible ureteroscopy for longer times. The time limit for stone intrarenal surgery for flexible ureteroscopy, it's about 90 minutes. Some would say 60 minutes, but in our center that's exceeding to about 3 hours, 180 minutes intrarenal surgery without any kind of complications postoperatively due to low pressure that we are using during the procedure. Therefore, in case you have a stable vision, you have a stable movements without fatigue, that also benefiting the patient in terms of surgery, that they have lesser anesthesia times and they have you can do more patients in a shorter time. So that's difficult to prove at the moment on a data level, so that you need first of all data to convince the other surgeons, all of. So I think this is going to come in a couple of years. The other thing would be benefiting tissue and stone recognition, where you would be more able to do in a quicker manner better surgery with a stone recognition there. Therefore, it's coming probably with the data, but not at the moment. It mostly benefits surgeons. And the other thing for the institutions would be whether these robotic platforms are going to be autonomous. Nowadays that they are fearing with the large language models, they are doing autonomous decisions. Probably we are going to have them in the robotic platforms with a more secure fashion. So I'll thank you for the question. And the cost differs actually from platforms to platforms. For example, it differs from country to country. The Monarch platform, I don't know the exact numbers, but they said to be more than 2 million the cost. The Zamenix probably about 1.5 million. The RoboFlex would be about half a million, something like that. But it depends from the institution that they are acquiring the devices. But I don't know the real market prices. It was just the things that I've heard. Yeah. And I would like to thank you once more. I'm one of the organizing committee in WCET in 2029. That will be very important for us to have you there, even though after 3 years. Thank you.
We'll be there. I think it is very important to say because we rarely listen about worrying about the physician, you know. I do have, I hope we can see it, this gerontologist from Colombia, Dr. Cuadros. I asked him and he suggested a conference on why we physicians age so badly. We can do what we tell others to do. And it's because we are so busy moving forward, trying to present, trying to innovate, to take care of the patients, that we forget about ourselves, our life, our families, and our health. So it is important. Those are tools. Worries me about availability. You know, we are in the sky with one foot and in a hole with the other because it's hard, but we need, nevertheless, to move forward. We will be there in Turkey. You can be sure of that. Thank you very much. Thank you. Wish you were here, Burak. Okay.